Thank you, Dr. Purinder, and thanks for giving me the chance to be standing on this stage. Dr. Purinder did show us a few cases with a Sionis tension ring. Once the Sioni tension rings works very well, then why do we need a segment? So that's the first question which might come to our mind, that if Dr. Purinder did say that he's done hundreds of cases with a Sionis tension ring, why think about a segment? I have no financial interests or relationships to disclose. Just before I start, I must also compliment his talk by saying that subluxated cataract is probably the only type of cataract that still poses a challenge to the experienced phaco surgeon. We can support the capsule as shown by Dr. Arup and Dr. Purinder by internal methods as well as by external methods. Internal methods could be endocapsular rings, the Sionis ring, or the capsule segments, what I will talk about. External could be the iris hooks or the capsular support system, the Makul capsular support system, which Dr. Purinder also showed that he was using the capsular hooks there. The capsular segment is nothing but a modification of the Sionis ring. It does not have a full circumference, but a bit of it, and that same eyelet which is coming above the circumference, circumferential arc. Now, why a Sionis ring is because why a segment is because the Sionis ring is flimsy and the surgery can be slightly tricky with a lot of sutures going in, trying to manage it and putting it in the bag. But with a segment, you can actually play around. You can actually pull it out of the bag whenever you want to. You are not entrapping any cortical matter behind it, and you can move it around and remove the cortical matter whenever you want to. You actually, in a similar manner, we now use a 9O prolene suture to suture it to the sclera. As I said, segments are smaller, easier to handle, and the Sionis ring has the advantage of a circular expansion of the bag, but that can be offset by adding a capsular tension ring, a regular capsular tension ring along with the segment if required. So I am showing this case. This is a 24-year-old male with a traumatic subluxation there. There was phacodonosis, and you can actually see the area of subluxation which is extending up to 4 clock hours there. We've made 3 paracenteses which are slightly more towards the limbus, and we're using the capsular tension, the external fixation of the capsular bag, and these hooks, rather than the iris hooks, are easier to manipulate. These hooks do not pull onto the bag in a similar way and are less sharp, and hence the chances of a tear, as Dr. Purinder was saying, is rare there, but it's still rarer here. Once the bag has been stabilized, a slow motion phacoemulsification can be done, and we have to keep on injecting viscoelastic each time we retract back outside the eye. Now, slow motion phacoemulsification has been advocated by Osher, in which the bottle height is lowered, the aspiration flow rate is lowered, as well as low power settings are used. Now that the bag, most of the cortex has been taken out, a coaxial IA cannula is being used, and each time we are retracting outside, we're injecting the AC with the viscoelastic. So after this, these capsular hooks are being removed. In fact, we could have implanted a segment inside the eye before we would have done the emulsification, and just with the hook get onto the iris eyelet and held it in place.
Excuse me, sir, nothing is visible there. We are not seeing the glow even.
So the capsular segment, this is the indigenous capsular tension segment ring, a capsular tension segment, which has been a 9-0 double arm prolene has been used to tie the central eyelet, and it has now been introduced into the anterior chamber. And it is a lot easier to push it inside and place it vis-a-vis a Sioni's ring. So as it goes in, you can actually pull it in and just place it inside the bag, and this secures the bag as well, in fact better than what a Sioni's ring would. We can tie the 10-0 suture there into the Hoffer's pocket, and this secures the bag pretty well. Once that is done, we can actually implant the IOL inside the bag, and as Dr. Purender said, that we can actually implant a single piece IOL now because we don't have any danger of any problems happening. So I'll go on to, I'm sorry about this, but these are the post-op pictures of the same patient. And you can actually see the single piece IOL in the bag with the bag secured onto the sclera. I think so this is another capsular tension segment which we are suturing outside the eye using a 9-0 double arm into the modified Hoffer's pocket using the rail track technique, getting the needle onto the into the needle and taking it out from the other end. We have to make sure that we're not getting any tissue into the 9-0 as we go out. So we take out one end, and similarly a second end about 2 millimeters away from the first. Is railroad. So that's the second needle which is going into the anterior chamber. And we're railroading it. And that's the second one, and now we will introduce the segment into the anterior chamber. This easily moves around, and unlike a Sioni's ring, which is difficult to implant, this also goes in through a 2.8 millimeter incision. You can't go in through a 2.2. So as this goes in, you can easily secure it, manipulate it inside the bag. So this is just manipulated there, placed the first eyelet into the bag, the inferior one, and similarly the second one. And as it is placed there, you can tie it to the scleral and make sure that you're burying the knots under the Hoffer's pocket. So the knots are cut closely, and after this, IOL can be implanted in the bag, which is secured, and the advantages of IOL in the bag cannot be re-emphasized. So these are the post-op pictures day one with the patient had a vision of 612 partial, and thank you.